Let me introduce Dr. Justin Elikofer, hailing from Evanston, Indiana. The gentleman in the teal polo, weighing, I'm just kidding. I'm not going to do your weight. I don't even know what that is. He's taller than me. He's better looking than me. He started off his dental career out of Evanston, Indiana, doing a travel surgery rotation, IV sedation on top of general dentistry. He's going to have way more fun facts for you. Here's the cool thing. He started doing sleep in 2018. He's done over 1,000 cases hands-on himself. So he knows what M.A.D failure looks like, or what at least it sounds like from the patients. So I don't want to steal his thunder. Dr. Elikofer, hit it up, man. Why don't you take it away?
What's up, guys? Thanks for coming. As Mike just said here, all the way from Indiana, in Tampa, Florida now, having a hell of a time. It's good to be in Florida. Come down, hang out with us. And you can see here, this is a picture of my wife and I. You know, we like to have a lot of fun. This is a Halloween costume contest that I think we did pretty well on. So dressed up as Slash there. Sarah, my wife, she's a dentist as well. She's dressed up as a little groupie. As Mike said, you know, I've been in Tampa. I've done a lot of sleep here and became a diplomate. And so really just here to talk to you guys a little bit about what I've learned in that journey, and really what success and really what failure looks like overall. Please, you know, ask more questions. I'm going to give really, 10,000 foot viewpoint of success and failures. We've all been out there doing these devices. We all have our specific questions. This is going to be so much more fun and have so much more value if you guys are asking questions and we can get those answered for you. Because if you're asking the question, someone else is probably thinking of it as well. So as I say, let's rock and roll and let's get started. So, you know, today we're really going to talk about defining failure. And in order to do that, we have to talk about what that is. What is M.A.D failure? When we're in our general dental practices and we're prepping bridges and or we're doing dentures or replacing implants, each dentist is going to have a different definition of what quality is, what aspects are important. And so we're going to see that same thing when it comes to sleep apnea treatment. You know, failure could be a device breaking. It could be just the patient not liking it or what their perception of failure is. So we'll define what those could be, as well as really just talk about what success is. Obviously, before we talk about failure, let's talk about what success is and what that really looks like. We're going to talk about that with our physician friends. We're going to talk about that with the patients, and we're going to talk about it internally with ourselves. So as I said, the good news is there's honestly a lot of different ways to fail when it comes to sleep apnea, but you get to define that. So you define your failures, you define your successes. Just know that no matter what we're talking about, there's always hope. That's the one thing that's great with dental sleep apnea treatment, is that there's essentially an infinite number of possibilities of really things to try with these patients. Whether it's different devices or different positions, those are the easy ones, right? So if our heart is in the right place and we don't give up, there's a lot of hope there. So let's first talk about, go ahead.
Dr. Justin, I know you're 2 slides in, but I have to ask you, that sounds like a Hallmark answer. We get to define our own failures.
Yeah.
Give us your definition. Like, you're, as the dental sleep medicine practitioner, how do you actually define failure? And I know you'll get into patients later.
Yeah. So I define failure as really, for me, I'm a people person. I care about the physicians. I care about, my dentistry, but for me, I'm a people person. Again, this is different for everybody. I'm a people person, so I care what the patient cares about. So in my consults, when I'm having these conversations with the patient, I want to define what failure is for them and what success looks like for them, so that I can focus on reaching those levels of success and preventing those levels of failure. Does that answer your question, Mike?
Yes. Thank you, man.
Yeah. So, when we look at failure, the first people that we hear about a lot saying that these devices don't work or that may be in your ear the most are really the physicians. Physicians really see failure as, an inability of the device to reduce the AHI. And even so more than 50%. So these physicians are they're just gonna say, hey, these devices don't work as well as the CPAP. They're also gonna look at these SpO2 readings. They're just gonna question a lot there. And so we have to be prepared for that. And we have to be able to really to have those conversations with the physician prior to treating their patients. And so we need to set the expectation of what a successful treatment is in dental sleep medicine with the physicians. You can see here in table 2 is a nice study done, and it gives us general guidelines or general values really that we can share with these physicians. We got to set the expectation with the physician just as much as we need to set the expectation with our patients. So when a physician says, the AHI is not reduced, we need to be able to get to these values and share this, that, actually, when it comes to mild patients, we're pretty darn effective at reducing the AHI. And when it comes to moderate, why we don't always get them below 5, we are seeing very large success in getting them below 10. There's a lot of research out there that supports that if we can get these patients feeling better and below 10, their comorbidities and their risk of early death is much reduced. So see here, you can see severe. We're gonna have these conversations with the physicians, and so the dentist, they're going to define failure in a little bit different way. So patients can be upset. I think the biggest frustration for me, starting, was really getting these devices to fit properly. Are they seating fully? Are they occluding correctly? And so really for me, that was the biggest thing. We hear a lot about TMJ. A lot of our patients will come in and question us about their jaw joint. Is this going to hurt the jaw joint? And us dentists are worried about that too. The last thing we want to do is do harm to our patients. And so that can obviously be a big failure point. Patients, again, my most important thing is the patients. I don't feel better. The patients say they don't feel like it's working. And so we really have to define what they want to feel better. And when we can define that, we can really set an expectation of, I can get this better for you. The number one thing that I see as far as promising or setting expectation is really snoring. Snoring is one of those symptoms that for myself is pretty easy to eliminate. So I get pretty hefty on the promises there, but we have to understand that we don't, as we're in the, we gotta, as our medical professional here treating a medical condition, there's really not a lot we can guarantee. I try to compare it to going to the ER, right? You had a family member, they just came into the ER, and we're trying to stabilize that patient. When it comes to sleep apnea treatment, the first thing that we're trying to do as dentists is really stabilize their airway. And so the ER physician in the hospital is never going to come out to the waiting room and promise you that everything's going to be okay and we're going to get this fixed. They are going to promise you that they're going to do everything they can to help your family member. And so we should be doing the same thing. We're going to do everything we can. We really need to get this airway stabilized, and then we'll move on from that point. So, again, big picture stuff. Man, we could talk about failure for so long. There's a ton of different ways to fail. What you think is failure may not necessarily be failure in the other dentist's eye. So first off, really understand what you think failure is, and then we can work from there. When it comes to patients' perception of failure, again, this is where I kind of hone in and spend a lot of my time. Patients can see failure as hurting, right? I always let the patient know that some discomfort is normal, right? You're going to have tooth pain. You could have, my informed consent says that you could have tooth pain, jaw pain, or muscle pain. We're we're stabilizing your jaw in a position that is different from your current position. It's going to be a downward and a forward position. Just like when you go to the gym and work out, you're going to have some sort of soreness or possibly pain. I do reassure them that it is not normal for that to be a long-term event. I use the word transient. Hey, that pain, any sort of soreness, tooth sensitivity is transient, should only last a couple days. If it lasts longer than a couple days or even a week and it's not manageable, definitely give us a call. We want to stay in front of that, but we don't expect not to have anything. I do a lot of implants. I do a lot of surgeries as well. I don't send those patients home and say, hey, you're not going to feel a thing tomorrow. No, I say peak pain is 24 to 48 hours. Expect some soreness. If there's anything you can't handle, give us a call. And so when they come back and they say, well, doc, I did everything you did. I did have some soreness, but this device just isn't working. I just don't feel better. There's really some things that we really need to talk about first. One, are they wearing the appliance? If it's comfortable, they should be wearing that appliance. But ask them, really grill them. It's easy to say you floss. It's easy to say you work out, and it's easy to say that you're wearing these appliances. So if they're not feeling better, are their bed partners feeling better? Have they noticed any improvement? Some of our patients don't want to feel better, and they don't want to be wrong. Maybe they're not in our chair for the right reasons, and they don't want to admit that, hey, yeah, maybe this thing is working. Maybe my wife was right. I'm probably guilty of that just as much as the next guy. So what other sleep habits do they have? A patient comes in and say, doc, I've been wearing this thing, and well, when do you go to bed? Well, I go to bed at midnight. Okay, that sounds a little late, but that's okay. So that's some people. Oh, but I get up at 5 a.m. I have a patient that he's in IT, and he goes to bed. He goes to bed later than midnight. He goes to bed at like 1 to 2 o'clock in the morning, and he says he has to get up for work at 5 o'clock. No matter what device we have in those patients, they're just not going to feel better, right? The good news is they can't have much sleep apnea. They're not sleeping that long. And so ask them what sleep habits they have. A great resource to have in your back pocket is a sleep hygiene, some sort of sleep hygiene pamphlet. We can get you some of those. There's a lot of them online. Are you going to bed at the right time? Are you withdrawing from caffeine at the right times of the day? All sorts of little things there that can really make a big impact on how well you sleep overall. Also, you want to revisit your initial notes. And 90% of the time, there is something positive that has probably come about with this device and my interaction. So really trying to find that nugget, keep the patient positive, keeping the patient engaged is going to be super, super important. And revisiting your notes on this is what we're here to accomplish. And this is what we have accomplished. So keeping that positive. My favorite type of patient, I honestly feel I can't fail, is a patient that's tried CPAP. Hands down, easily my favorite patient. They come in, the main reason being that if they perceive failure, if their physician perceives failure, or I'm not happy with the result, they failed CPAP. So there's less onus on me. You know, they have to own that this is a condition of their body and that we're doing all we can, but there's certain limitations. And so when they come in and they've tried CPAP, it's a hard conversation, right? I tell patients that 30% of my patients, you know, may not be happy with the effect overall. And, you know, those are 30% of really hard conversations. But when they've tried CPAP and it's failed too, you know, we did all we could. We tried CPAP, it didn't work. We tried this, it didn't work. Have a next step. And that next step is a referral, you know, either to an ear, nose, and throat, or maybe a doctor to talk about other types of therapies overall. So we've talked about failure. Again, you guys, you know, write in the chat box, you know, what you would consider failure. And I'll try to speak to some of those. And Mike, you can give me some ideas and, you know, our patient's perception of failure and how I might respond to those. So one of the easiest is really what is success. A lot of the AADSM in particular defines success as 50% improvement with an AHI. Ideally, we want that AHI below 10 and a 50% reduction. But just like we can't come together as a cohort and define failure, we really haven't come together and defined success. I mean, you can see that all the way back in 2016, the Journal of Dental Sleep Medicine was saying the successful treatment of OSA should not necessarily be a number, whether it be 5 or 10. It should be a combination of outcomes and ongoing assessment. Are we getting the patient better? Hopefully, we can move beyond that number and work towards a more patient-centered and a relevant definition of success. And so that goes back to what I believe is, you know, let's focus on the number. Absolutely focus on the number, right? We know the higher the number, the more likely, the more at risk these patients are for diabetes, heart attack, stroke, cardiovascular disease. We know that that's correlated. So we can't just throw it out the window for sure. But we really do got to continue to focus and continue to put emphasis on with our patients and with our physicians that this is more than just a number, and talk about how they feel. We can look at all sorts of different things like, you know, effectiveness equation, you know, hypoxic burden. There's all sorts of things out there that a lot of different dentists and a lot of different organizations are talking about, and it's going to be exciting to see where they end up.
Yeah, Justin, I got to hop in here because you asked for it, and we had some folks respond in the chat. But
perfect.
Before I hop into that, I just want to bring something out, you guys, that he said kind of in between the lines a few times here. Your patient's perception of success is going to be based on how they feel. The AADSM is defining success in treatment based on numerical values from sleep tests. And those two things aren't always aligned. I mean, we can't raise hands here, but how many of you have, you've had,
I think we can wave, can't we?
Can we? Oh yeah, we can wave. How many of you guys have had patients that they come back after, you know, you give them the initial delivery, they come back 3-4 weeks later and they're like, oh my gosh, you saved my life. You're like, yeah, we got to test you. They're like, well, you don't trust me? You're like, no. And then when you test them, they still got massive amounts of apnea. They feel better. But, you know, that's the underlying thing here. Yeah, bunch of thumbs up. This is going to happen. So, Justin, what you're hitting on is this is the underlying part of patient communication, which is crucial because how they feel is what's going to define their perception of success. All right, let's get into everybody else's comments here because you asked for them. So,
yeah,
top patient failures or complaints. Can you see them?
In our chat.
Yeah. Brian said patient can't sleep with the appliance.
Okay. Why can't they sleep with the appliance? I mean, that's What is it? Is it too thick? Is it gagging them? There's a reason they can't wear that. And there's a lot of different, I mean, without getting into the weeds, there's just a ton of different devices out there. And there's a ton of different modifications that I can make to a device to get that feeling better. Without getting into the weeds, that's what I would say. You got to ask these patients lots of questions. What is it? Keep delving down into what exactly it is. These devices are so comfortable and thin now. There's not a good reason to say I just can't wear it. I don't think, but I can usually figure that out. It takes some conversation.
Yep. So Andy said mobile teeth. Andy, I'm assuming that doesn't mean you've created mobile teeth with your appliance. They already had some perio. Dr. Justin, you want to hit that?
Yeah. Again, so mobile teeth, I would ask for, I'm not going to keep saying this, but I'd ask for a little bit more information. I'm a big fan. If you do have, it sounds, I would say the opposite. Maybe you induced some mobile teeth. I let patients know that that's in our informed consent, especially when they have perio. I use the example a lot that your teeth are a fence post. Your teeth are going to be supporting your jaw and stabilizing your jaw. And there's going to be force on them that hasn't been there before. And it's okay if we do get some mobility. We absolutely want to track that. We don't want it, we will come to a point where we maybe have to withdraw treatment. I can't think of a patient that I've ever been like, don't wear your device, your teeth are too mobile. What I have done in the past is splinted the teeth together with like a lingual retainer. It's usually those mandibular anterior teeth. It's usually perio involved teeth. So having that conversation with the patient at the very start and saying, hey, there's some bone loss around these teeth. We got a bunch of fence posts with half dirt on them, and they're going to move around when we start putting some force on them there. So for us city kids, fence posts and dirts isn't the perfect analogy, but I'm sure you got something else in your arsenal. Yeah, well, that's what I use. People get it, I think. So got another one here for you. Yeah. Hey Kent, how are you doing, buddy? Yeah, I need to go get my cowboy hat. Follow me on Instagram, Tampa Dental Cowboy. I'm doing a lot of cool stuff, by the way. I think Ken will appreciate that. When a dentist convinces them that a change in their bite is not worth breathing during sleep, we see this a lot too, right? I mean, pick your poison. What do you want here? We can only do so much with our tools. The nice thing about being a general dental provider like myself and not being in a sleep-focused practice is we also do Invisalign. So we can talk about that, talk about getting those teeth in a more correct position that now, if we move the teeth into that correct bite and we get them in appliance now, the forces are going to be different. So the likelihood of that bite changing again is going to be a lot less. Patients are going to be a lot more observant of that. And so they're going to use their AM repositioners that we use to help realign those bites and all that as well. We're getting a lot of questions. Go ahead, Mike, pick another one. Yeah. Side sleeping and pain with lateral fins or herpst. Yeah. Adjustments or appliance change. Pick a device that doesn't have lateral fins or herpst, right? They're out there. And so super easy. Okay. Pick one that doesn't. Yep. Stan, he made a MyTap at the end of January 21. Wife was using AM aligner intermittently 2 months ago. She knows she couldn't chew on her back teeth. Yep. Has to chew on her anteriors. When she closes, she only contacts the linguals, the maxillary anteriors. And yeah, go ahead. Yeah. So posterior open bite. I mean, this is the thing that we run into. Again, setting the expectation. This is in our informed consent. I talk about people with really what I would consider tight bites versus a lot of overjet or a lot of overlap. There are certain subset of patients that are going to be more predisposed to changes in bite. I tell a patient, my goal is to reposition your jaw in the morning. We're going to hold your jaw out at nighttime so that you can breathe. But in the morning, it's going to be important to reposition. I need you to see it. I need you to feel it. And I need you to hear it. I want you biting down on that. And I want you to verify. If you verify that every day, it's very unlikely that we have an issue. But I will tell you up front, the further we have to hold your jaw out, the more likely we are to have issues and complications. The stronger our mandibular advancement devices are drugs, the stronger the drug is, the more titration, the more forward we have to push the jaw, the more likely we are to have these issues, tooth mobility, bite changes. So that's going to be important in our conversations as we're adjusting this on how they feel and what values we're getting on that titration. When is it enough to send them back for a follow-up sleep study? I typically lean to sending them off as soon as I can. I just want to, I want to get them back to their physician and get them tested, because who knows, everybody might be happy at that position, and we're going to have less issues, less complications with least advancement.
Yeah. And just to drive that one home a little bit, I mean, to Kent's pointed question here, and also Dr. Villag's question about open posterior open bite. At the end of the day, if it is between chewing on your back teeth and the patient's not complaining and breathing,
Yep.
I mean, we got to put things in order.
In perspective.
Yeah, good questions, you guys.
But again, we're dentists. I mean, we can't just say we don't care about the bite, because that's all we talk about in my general practice, right? They come in, new patient comes in, we're talking about Invisalign, we're talking about occlusion, we're talking about the importance of wear on the teeth. So, we can't just completely go away from that in my line.
Yep. Yeah. So last one, maybe give us the question from David. What's your favorite appliance to use, or with the least complaints, i.e. fights and TMJ symptoms? So, I mean, you've done a few.
Yep.
A lot.
Yeah.
Types of patients, because I know it is going to be patient dependent.
So what I found is no matter what device you use, your TMJ symptoms will be lessened if you start at a bite that is relatively equivalent to their maximum intercuspation or their centric occlusion. Call it what you want. But when we have a patient bite down and we measure their overjet, if you're not starting that patient out in front of that position, I find that we really I don't have a lot of TMJ symptoms, particularly with one device, to be quite honest. My favorite appliance we use, I think the worst thing you can do as a sleep doctor is pick one appliance. One size doesn't fit all here. I give patients a lot of onus on the appliance type. I use ProSomnus, I use SomnoMed, I use Serena. Those are definitely my top three that I see in those patients. Getting back to lateral fins, the Serena doesn't have side fins at all. SomnoMed, makes a really nice Herbst and dorsal. And then ProSomnus is just a very sexy device, easy to show a patient, and they get excited and it doesn't look obtrusive.
Yeah.
So
I just got my new Evo 2 weeks ago, and it's been a minute since I've had an appliance, because I've been on an apnea journey for a long time. That's not why people are here. But anyway, it was slick. Yeah. Super minimal, dialed in. Anyway, go ahead, man. Great questions, y'all. Keep them coming in the Q&A, or throw them in the chat. We'll figure it out.
Yeah, it's more fun to talk about it than to hear some slides. But getting back to it, starting the case off right. Some of the best things that you can do in your consult is under promise and over deliver. When I talk to my patients, the number one thing, I've already said it, but I'm going to re-say it again. I let them know that it is normal to have some sort of tooth sensitivity, muscle soreness, or jaw soreness. If that happens, please don't call me and freak out. It's expected. We're holding your jaw. We're pulling on your muscles in a different movement than we ever have before. It's normal. I want it to go away. I want it to be manageable. If it's not manageable, give me a call. I'm here for you. We'll figure it out. Typically, if there is jaw soreness, especially jaw joint, it could either be clenching, or likely the device isn't hitting evenly on both sides. So I have that patient come in, a week or so. If they're calling me a week later and say, "Doc, this thing is still sore," there's probably something that I missed at the delivery. I mean, I try not to miss too many things, but I probably missed something at the delivery. So number one, start your case off right, and set that expectation with the patient. Hey, it's likely we're going to the gym. This is our first day going to the gym. It's likely that you wake up tomorrow and have some sort of sensation. I don't say discomfort or pain. You will have some sort of sensation there. Also, I let them know that this device is not perfect. When it comes to treatment, there's CPAP, there's dental device. Neither of them are 100%. I tell the patient there is 70% chance of all my patients, 70% chance that all three of us will be happy at the end of this. Your physician will be happy, I'll be happy, and you'll be happy. And you'll want to use this as just a lifelong treatment for you. There's an 80% that probably two or three of us, or 1 to 2 of us will be happy. I really say 2. And then there's about a 90% chance one of us will be happy. Either I'll be happy because I feel like I did everything I could, or maybe we got all the parameters down to where I wanted. Maybe the physician will be happy with the AHI, but the patient won't be happy with the symptom improvement. Maybe I just don't like the fit of the device. Maybe the patient's more open and just looks uncomfortable. So again, I tell my patients in their consult, 70% of the time, everybody's going to be happy. 80%, 2 people, 90%, one of us will be happy. I also tell them that as your apnea gets worse, we're reviewing these sleep studies with the patients. As your apnea gets worse and as your BMI, I don't call them obese or anything. They tend to know what I'm saying. I say as your apnea is higher and as your BMI is higher, there's less likelihood that this device will work for you. And so we got to be cognizant of that. That'll lead us into some other conversations about weight management and life cycle. What's the word I'm trying to find? Can't find it. So we're going to move on. But explaining that, this is a collaborative approach, and it's just not as simple and cut and dry as we may. So again, we likely will have some sort of sensation or feelings for a couple days that's transient, and then the likelihood of success, 70%. And what is that? Define success. My goal here, you just told me you want to quit snoring and you want your blood pressure under control. Perfect. I expect that we should get some snoring, and I expect that we decrease your AHI by half. Will we get your blood pressure under control? Maybe, maybe not. We just really won't know until we see that. So describing the process that this is not something that is achieved overnight. I can't give you this device and you be better the next day. And so that's really the best way to start it, is hitting that stuff right in the forward. And when you guys are out there doing crowds, by the way, is anybody saying, "Hey, I know I can guarantee you're not going to need a bite adjustment"? I certainly don't. Maybe there's some better dentists out there, but who's out there guaranteeing that their implants are going to last a lifetime? That's not me. So, we gotta start the case off, under promise, over deliver, do everything you can.
And I would sum it up, you guys, and say that anything like what Dr. Justin is talking about, anything that you educate the patients on in the beginning is just education. Anything you tell them about after the fact, after it's occurring, they perceive as excuses.
Right.
Education versus excuses. Justin, question for you, because there's a couple versions of this. So I'm going to sum it up because you started talking about referring out and collaborating with physician colleagues, i.e. weight management, that kind of thing. At what point do you inject that, not the referral, but at what point do you inject that part of the conversation with the patient? Meaning, at what point do you talk to them about the possibility of collaborating with other physicians as a holistic care plan instead of just the appliance?
So I usually do that at my consult appointments. A lot of us are dentists in our regular practice, so we're screening these patients. So that's when I introduce it. Hey, patient, your BMI is X. They usually share that that's something that they want to take control of. And there's physicians out there that are double boarded in different not departments, but sections or whatever the heck the word is. Specialties. Thanks, man. I couldn't live without you, Mike. Different specialties. So, when the patients are having sinus issues, obviously we want to work with ear, nose, and throats that do sleep testing, that treat this. If they have COPD, we may want to work with a pulmonologist. If they have weight issues, we may send them to somebody. And the patients get excited. I say, hey, I got this great idea. I have a physician that does X and Y. You talk about both of those, and we can kind of double dip and, really only spend one copay. They can do the sleep test, and, you can also talk about, getting control of this. So that's when I interject it, is really at that first appointment. And like I said, a lot of us dentists who are screening for it, that's the perfect time to say, hey, I see a couple of different problems here, man. Your blood pressure was 140 over 90. I had a patient the other day we were doing wisdom teeth on, and she had tachycardia. I mean, we hooked her up before we gave her anything. Her heart rate was 100, and we were like, what are you, what's going on? Well, my regular physician said this and that. Well, let's get you to a cardiologist that also can help us with this. And that's a really great benefit for the patient.
Awesome, man. Cool.
Patients need to take ownership, right? The worst patients are the ones that don't want to be there. Those are really easy cases to fail, right? The patient doesn't think they have a problem. They're just there because their physician told them they have sleep apnea. They're in your chair. Again, being general dentists, the patient that hits all of your screener questions. Hey, patient, you're snoring, you have high blood pressure, your airway looks a little crowded. And they just don't care. They just want to kick the can down the road. I feel it's our job to have the conversation, but the patient really has to take onus and take ownership, whether they have been diagnosed with it yet or possibly may have it. They need to understand that the risk factors and how they correlate. Patients, you need to verify compliance. Again, there's no good way other than asking them. You'll kind of know. Again, the patients who don't take ownership really don't comply as well. And did they follow your instructions? This is, this really gets to more advancements and patients being uncomfortable. So, I've had patients before, they call me and they say, doc, this is wrecking my jaw. What did you do? And I say, well, come back in. And they didn't follow our adjustment protocol. They have it out. Well, the magic answer you see probably 30% of the time is, oh, I thought we just should get out as far as we can go, and that was better. So they likely didn't follow your instructions, whether it's an adjustment instruction, whether it's doing that AM aligner, right? Bite always comes up, another big thing. So take care of themselves. We've already touched on that, so don't really want to touch more on that. But sleep hygiene, exercise. The more exercise we have, the more energy we have, the better we sleep. It's simple things that are not simple to do when it comes to living life. I'm trying to exercise and get healthier, and trying to balance practice and kids and all that other stuff.
And have a baby. Boom
And a
shakalaka.
baby coming in May. So that'll be fun. So coming up really on the last slide, at the end of the day, we put on a level up course, kind of intro to sleep. And I think it was a week ago, 2 weeks, whenever we were doing that, it's hard. Doing something new is hard. I recently purchased a practice, and I'm placing a lot more implants and doing a lot more surgeries than I ever have. And getting back in there is sometimes scary. And I get it, but we got to be confident. These devices, they stabilize the jaw. I would tell anybody that all we're doing is we're stabilizing the jaw. I tell patients I have never, because this is true, I have never caused any sort of permanent temporomandibular joint dysfunction in any patient before. These devices can be withdrawn, treatment can be withdrawn, and 99% of the time things will resolve just on doing that. It may not go away day one by any means, but they usually resolve on their own. And I also tell our dentist friends that who's out there right now that gets concerned when they give a patient a night guard. I mean, I've seen some of these acrylic night guards. They're at least 3 millimeters thick on the occlusal. I never hear dentists saying, "Oh man, I gave this patient a night guard and I'm just really concerned about their jaw joint." At the end of the day, we tend to help the jaw joint more than hinder it. We help protect it. We can add modifications to our appliances to decrease muscle activation. There's lots of different things that we can do to actually help the jaw joint. So I tell my patients, hey, you're going to read my informed consent. I think there was a dentist out there somewhere that, didn't know what he's doing. I don't know what happened, but somehow it made it in my informed consent. And just like those pharmaceutical companies say you can die, mine's going to say that you can have some jaw joint issues. How are we going to prevent that? We're going to start you back in a comfortable position, and we're going to adjust you slowly over time so that it's comfortable. And that's how we're going to prevent that from happening. If we have any issues, we'll withdraw treatment and we'll reevaluate. Be their advocate. Again, don't give up on these patients. That's harder to do with some patients than others. We do not have a good system to look at a patient and say, this is your protrusion. This is the protrusion, and this is what's going to be the maximum effectiveness position. We'll get you there. We'll send you back, and what's done is done. We have to try as many positions as the patient will allow. I can usually outlast my patients. I want to fight for them. I want to be an advocate. And if you do that, patients will see that. So even if it doesn't work, if I've studied them at 5 different positions and I've sent them back to their physician 2 different times, and we have 7 different sleep study tests, they're probably pretty exhausted at the process at that time. And they'll understand that, hey, doctor's done all he can do. My body's just not reacting the way that we want it to. We can open these patients up, right? I always start off with a minimum occlusal space because that's more comfortable. Again, we have less issues. I try to start them back at the position that their jaw is at awake. And then if I really want to get creative, I can start adding incremental opening to that, see if we're getting any changes there. And so, sometimes most of these patients are finished within 2 months. Have I had patients that are 4 or 5 months? Absolutely. And so just be their advocate and do the best you can. If your heart's in the right spot, you really
All right. This is one of those moments with Dr. Elikofer's frozen. I think we got an internet thing going on here. All right, everybody. So I'll hop in here. Hopefully that internet speed figures itself out there. I love what he talked about with relation to the patient's perspective tonight. And I mean, we're coaches here. We want to have the patient's best interest in mind always, and give you all the verbiage, the tactics to actually communicate that to them. He was dropping a lot about how they feel. One thing that he didn't quite articulate, but started saying in between the lines, he's always going for maximum medical improvement with the minimum titration possible. So the idea is getting the patient comfortable, not making sure you got that midline in line, making sure that you're not starting them at a super forward position that's uncomfortable, that kind of thing. Anyhow, we got some questions here. If you guys have questions still, please throw them in. I'm sure he's going to hop back on here as soon as his internet will allow him to. Yep, he's coming back. I just got a text from him. So, Simi Silver, I see that you hopped in the chat and you've got a presentation prepared about screening for your local community. High five. Good job on that. Juanita, you had said that the patient's wife, the husband or wife, their chief complaint is that they still snore after therapy. Dr. Justin was talking about that earlier, about setting patients' expectations, working on their primary concern, and then making sure that you're setting those expectations properly. You're going to attack that thing, but you may not resolve it completely.
Am I back? What the hell happened?
You're back.
Man,
I thought it was my internet, man. Yeah.
I think it was mine for sure. I apologize. Where was I left off. I was talking about Chat GDP. Did I get that out?
Nope.
Oh, shit.
You did not get that part out.
Yeah. Where did I leave off? Anything?
You were, I hopped in on just communicating their, you know what, I forgot, man. I said a whole bunch of stuff while you were gone. And I didn't even mock you with my one opportunity here.
I gotcha. Be the patient's advocate. I shared that, right?
Yep.
So be the patient's advocate, try as many positions as that patient will allow, do as much testing as they like. And, you really can't go wrong. At the end of the day, we don't have a system yet that tells us exactly what position to hold these patients at. I tried to ask Chat GDP, and it said it was not allowed to give me medical device. So I feel like, there's definitely not an answer. There is not a magic solution out there. So, and then, ask an expert was in the slide. So there's a ton of people out there that's doing a lot of these. They're usually pretty friendly, pretty helpful. Obviously there's experts like you guys, and, you guys can get anybody in the right direction, to help with any of these specific questions that people are asking, for sure.
Gotcha. Well, I guess, guys, on that note, we always have some type of a discount offer for course and stuff like that at the end of our webinars. So I'll hop to that real quick, and then we'll come back to these questions. Let me see if I can share screen and not break things, huh? Okay. You can see my screen. Give me a thumbs up, Justin. Yeah, cool. Okay. Awesome. So something you guys have not seen yet. You guys, that's California version of y'all. I didn't give that disclaimer. If you've heard me say it before, sorry, there it is again. We have a DSM marketing kit that we just put together. We've got large posters, small posters, and patient handouts. If you guys are looking for stuff, you can use the QR code here. We put together a small pack. I think it's 10 brochures, a couple of 4 or 5 of the small posters, and one big one for you guys to check it out for $100. So you can use the QR code, see if you like it. If you do, wonderful. We'd love to get you more of those. Anything that we can do to help you have more conversations, good conversations with your patients. That's the goal here. Also, we have our level up course. Dr. Justin mentioned that this course, he's actually going to be the speaker. So if you liked him tonight, round of applause, give him some hearts and thumbs up. But if you liked him tonight, there's a lot more of him in the level up course. It is Friday, April 21st. It's an 8-hour day virtually on Zoom, except that one, we can see your faces too. So you can't fall asleep or snore or yawn. Just kidding. No, but we really do want to see you. If you feel like you can benefit from any verbiage points or more interaction with Dr. Justin or our team here, guys, we'd love to have you. We discount it to $297. That's for one doctor plus 4 team members. Again, the QR code is there and you'll get a link as well at the end. And then the other thing is we're coaches at heart. So if there's something that we can answer for you, this is free. It's on our website, or you can use the link there. If you've got questions, we will absolutely give you the best answers we've got, or we'll point you in the right direction. One of the two. It's a 25-minute call. You can schedule it if you'd like. Ask us your questions. We're here for you. Here's what we don't want. We don't want this industry to continuously feel like an island. If you're new starting this out, don't not treat your patients because you're afraid of the TMD complications or it failing. That's why we put on webinars like this, y'all. We want to be the community here. So we're here to serve you. If we can answer questions, Doc can answer questions. Yeah, that's what it's all about.
Did I get to say my mouth guard thing? Did everybody hear that part? The mouth guard?
You're going back. Yes. You actually talked about the 3mm night guard that everybody wears.
These things, get them in there, right? Get your first tooth extraction, place your first implant, get comfortable being uncomfortable. And, you got to push yourself out of the box. You can do it. The likelihood if you follow our steps is the likelihood of you doing something maleficent or terrible is very unlikely. So this is a safe, FDA cleared treatment. Removable. Patients ask me that all the time. Do I have to wear this all day? Well, shit, I didn't do a very good job of explaining what's going on, did I?
Nope. That's a redirect for your consult, and your sleep champion's looking at you like
I failed. Yeah. Right.
Okay, so thank you all for the latitude there. Let's get into your questions. David wants to know if he's going to get your personal cell phone. I'm just kidding. Email address. Dr. Justin, you comfortable with us doing that? You want to put it in the chat?
I am. I'll put it right now. Please go to my website, help my SEO. That would be a big help. Personally. So that's all I ask. I always host and panelist. So it's DRE. So it's like Dr. E at dentisttampa.com. I don't know if everybody can see that. I think so. So
yeah, they can. It's in the chat.
So DRE, so it's like Dr. E at dentisttampa.com.
Wait, so Dre.
Like
Dr. Dre. I'm just kidding, man.
Yeah.
I'm giving you a new outfit for Halloween this year. Let's get into some questions. So you talked a lot about patient perception and their perception of failure. Can you please, there's a couple here. Can you please speak to what physicians perceive as failure, or conversations, if you want to highlight one on the physician side, what's perceived as a failure for an appliance?
All your physicians, just like your dentist, are really going to differ. So you need to ask your physicians what that looks like for them. When it comes, ask that question again, Mike, when it comes to patient subjective, what are physicians considering failure?
No, you have a lot of communication with patients, but you've had the unique opportunity to have a lot of communication with the MD side.
Right.
So when you talk to them, their perception is different. What do they perceive as failure with the appliance, or how have those conversations gone?
Yeah, I mean, 90% of them, a large majority of them, look at strictly AHI reduction and SpO2 readings. I mean, they're clinicians. You know, you go to your primary care doctor, you get blood work done, and what is it? It gives you a value, and it gives you a normal range and a high and a low.
Yep.
That's how they perceive these patients. You know, you'll send them back with an AHI of an 11, and you know that's not low enough for them. And some dentists feel that way too. So
Yep.
A large majority of them, and I try to let them know that I think it's okay that they feel that way, but I do want them to know that there's another piece to it, because at the end of the day, they're liable for these patients' care. So I get it. You know, if I went to the doctor and my thyroid levels were out of control, and they gave me medication and it only went down halfway, you know, they could in some way maybe be liable with that, which, you know, requires an organizational change on defining the success of this. So it gets into the weeds there, but most physicians, unless they really get it, unless they really truly get it, will only look at that number. And some of them aren't happy with below 10. You know, it's got to be in that normal range, just like your blood values of everything else.
Yep. So another question, Bonnie asked, is there a recording of the webinar? Yes, absolutely. After we conclude it tonight, you guys know that we put that up by tomorrow on our website. So you guys will have access to the recording for that.
For $4.99.
No,
I'm just kidding.
Wait, do I have that kind of voice? I mean, what are you saying here, man? Come on.
Yeah.
Yeah, no, you guys,
that's asterisk behind you or something.
The asterisk behind that is you only get CEs when you attend this live, because it's a live virtual attended webinar CE credit. So you can't get the CEs if you watch the recording, but we do put it on the website. You can also listen to it through Spotify if you want to just listen to it on your way to work, that kind of thing. Okay, so next thing. Wow, that was just like.
Yeah. What's another question?
Stopped.
No other questions out there?
There was one earlier.
Britton said I did a great job, so I think that's important to say. You know, it's not really a question, more of a statement, but I appreciate that, Britton, if I'm saying that right, Brenton.
Bonnie Renton, B. Renton. Yes, thank you, Bonnie, for the kind words. You actually got a bunch of thumbs ups and hearts. So I think people would like to hear from you more. I don't know, you guys. Don't inflate his ego here. Just kidding. So listen, we are at our 6 o'clock hour. If you have questions, please stick them in the chat or the Q&A. If you don't, we're happy to let you go around the 6 o'clock hour. Brooke, go ahead. Boom. There we go. She just put the CE link in there. So if you click on the link for the CE, it will take you to a quiz that is going to take you 47 minutes. I'm just kidding. 47 seconds to complete. There's a couple of check boxes. If you all would like more information about any of those topics that are on there, make sure to check those boxes and we'll send that to you. If it's the patient brochures, if it's screening materials, whatever it is. Like I said earlier, our desire here is to serve you as our market, as our industry. We want to not be islands, guys and gals. Please don't be an island. If you got questions, throw them our way, throw them Dr. Justin's way. We're here to help you. So you can go out and do more good work helping your folks. Dr. E. Dre, Dr. Dre, that's seriously going to happen, man. Any parting words for these kind folks that have given us an hour of their time?
Yeah, you know, it's hard when we have so many people probably at so many different spots in their, you know, dental sleep journey. Keep pushing yourself, keep having more conversations with these patients, keep delivering more devices. And, you know, there's no matter what it is in dentistry we're doing, whether it's a new procedure or a new sleep device, keep pushing the limit and, you know, keep agreeing to attempt to help and have your heart in the right spot and help as many patients as you can.
Yeah, completely agree. And push through the discomfort, folks, because it happens to all of us. Doesn't matter how long you've been doing it or short you've been doing it. The prize on the other side is you are absolutely impacting somebody's life for real. So thanks for what you
Don't
do.
push through the discomfort of your patients.
Thank you for the clarity.
You know, it's okay for you to be nervous. That's normal. I think nervousness keeps you on your toes, but if your patient's uncomfortable, don't push through that.
Yep. And last thing, if you guys do want more of Dr. Elikofer, he's going to be doing our level up course on the 21st. Love to see you there. Other than that, have a great night, everybody. We appreciate you.
See you guys.